Hi, my name is Kira McKinnon. I'm the Patient Education Specialist here at the Cross Cancer Institute, and I get to introduce our presenters this evening. So I'm going to start with Dr. Moore. He's a graduate from the University of Alberta, receiving his MD with distinction and honors in research in 1986. He completed his training in urology and research at the University of Alberta, receiving his PhD in experimental surgery oncology in 1991. Through his promotion to professor in the departments of surgery and oncology, he has been supported by the Alberta Heritage Foundation for Medical Research. He is currently the Mr. Lube Chair in Uro-Oncology and divides his time between research and clinical practice. Dr. Moore is an active member of the Canadian and American Urological Associations and the Specialty Societies of Urologic Oncology. Transplantation and renal vascular surgery. He is a reviewer for several specialty journals and has served on multiple research funding panels. Dr. Moore is a recipient of Mentorship Award from the University of Alberta by nomination of his graduate students. Please welcome Dr. Moore.
Thank you for that lovely introduction. This evening really focuses around what Dr. Basapa has to say, and I'm really given an introduction that I've done once before, but I think it has the key messages and from a surgical perspective about kidney cancer. How many patients in this room are patients with kidney cancer? So we're preaching to the choir or talking to people that have already had kidney cancer. So you've probably heard some of this during your treatment or journey in managing your kidney cancer. And hopefully we can highlight, why it was or why it is you're getting treated the way you are in this system. Kidney cancer is the 7th most common cancer. It's 6th in men and 9th in women, so it's more common in men. It's the 12th most common cause of cancer death, and it's a highly lethal cancer. So once you have it, unless you have it cut out and the cancer has not spread around, then in most cases this cancer will eventually take your life. The newer treatments are focusing on ways to slow down the cancer growth, or actually in some cases that are fairly rare, to cure it once it's spread around. The risk factors for kidney cancer are smoking, obesity, and high blood pressure. And in addition, renal failure is commonly associated with kidney cancer. There's also risk for it with genetic factors that you can be born with and acquired genetic abnormalities as you age, so mutations in your genes. With time, there's been a stage and age migration of kidney cancer, and I'm going to highlight that in my talk. Basically, we didn't have diagnostic imaging where you could detect cancers early, and kidney cancers are hidden in behind. So you used to have to present with very large masses or large tumors that caused significant problems before it was ever detected. With new innovations in radiology over the last 20 years, most kidney cancers nowadays are detected very early. This is the anatomy of the kidneys. They're hidden in behind. Blood goes to the kidneys from the aorta, which is the big pipe coming out from the heart, and it goes back in the inferior vena cava, which is the big vein taking blood back to the heart. And each time your heart beats, about a quarter of the blood flow goes out to the kidneys to be filtered. So each kidney has about 800 to 1,000 mils a minute flowing into it to be processed, filtered, and cleaned of toxins. The workhorse in the kidney is this little rascal here called the glomerulus, and it filters the blood and produces the urine. But the urine that's produced, there's a large amount of it, and it has to be reabsorbed in the tubules that collect the urine after it's produced by the glomerulus or the filter. these cells in here are very energy dependent, and they require oxygen and energy to keep active. And the cells also have a lot of pumps in it for dealing with toxins that they're trying to get rid of. So they can pump toxins out of the cell, and they also have things to prevent against oxidative damage, so free radicals and everything. So most of these cancer cells are resistant to conventional chemotherapy, and they're resistant to radiation. More resistant than the kidney itself. With aging, there's a loss of kidney function measured in glomerular filtration rate. So that little workhorse that I showed you, as you age, it gets damaged and it cannot produce and filter as much urine. And you can see that with time, the glomerular filtration rate drops from over 100, below 90, which is considered early stages of chronic kidney disease, to when you're quite elderly, then there's less kidney function. The risk of developing chronic kidney disease, or disease that could eventually lead to dialysis or renal replacement therapy, is quite variable, but these are the highest risks for the different stages of abnormal filtration rates. And you can see that a large proportion of the population has a glomerular filtration rate between 30 and 60, so a quarter of the population as they get older. If we look at what's called epidemiological studies of renal cell cancer, besides being exposed to toxins and aging, the things that also are associated with kidney cancer, especially in men, is chronic kidney disease. So this is looking at people with a early chronic kidney disease in men versus women, and you can see that the incidence of kidney cancer is higher in people that have chronic kidney disease in men than in women. So there's some form of protective effect in women. The latest discoveries in kidney cancer focus around what's called molecular biology, or the study of molecules that signal and tell the cancer cells what to do. And a lot of this work has come out of NIH, the National Institutes of Health in the US. This is a paper published by Marsden Linehan, and the geneticist was Burton Zabar. Marsden Linehan is a urologist that works at NIH and a research scientist. And clear cell type renal cell carcinoma, which is the most common, it commonly has a mutation in cell signaling involved around the generation of vasculature, so blood vessels that supply blood to the tumor. The papillary type, which is the second most common form of kidney cancer or renal cell cancer, has signaling abnormalities involved around hepatic growth factor, or the c-Met gene, so another growth factor gene. And then the papillary type 2 is interesting because it has abnormalities in cell signaling around the use of energy and mitochondria. And the mitochondria, the power plant of your cells, and these power plants are also the key controller of cell death. So when a cancer cell is abnormal, it sends out signals that it's abnormal, and as the genetics in the cell get more abnormal, it signals through the mitochondria that you should probably not live anymore and die so that you're not generating more abnormal cells. The chromophobe type tumor is related to another overgrowth of a cell proliferation through a gene called folliculin, and it's inherited in diseases known as Birdhog-Debye and tubular sclerosis. And you can see these people with little nodules when you're walking around that have overgrowth of certain types of cells. And this overgrowth or stimulation of growth causes the kidney cancer. So you can see that it's related to cell signaling kidney cancer. And then the newer research is looking at ways to stop or control the cell signaling that's abnormal from these cells. These cells are not foreign to you. They're your own cells that have developed an abnormality that then causes them to grow out of control and not to die. Hereditary renal cell cancer versus non-hereditary renal cell cancer is different. So if you already have a gene that's abnormal, if the other gene becomes abnormal in time, then you're more at risk for developing cancers. And these can either be growth factors or things that suppress tumor growth. They're naturally occurring cell signals in your tumor. The sporadic type of renal cell cancer tends to occur only in one spot or in one kidney, and the chance of it occurring in another spot or another kidney is actually quite low, less than 5%. Hereditary forms of renal cell cancer tend to occur in multiple spots, and they tend to occur in both kidneys. It becomes very important in the management of hereditary cancers that you preserve as much kidney function as possible. The most common genetic abnormality for renal cell cancer, it led to a lot of the studies, is a gene called von Hippel-Lindau ligand or von Hippel-Lindau disease. And it's basically a compound that gets rid of a stimulant in the cell by binding it up, called ubiquitination, and getting rid of it so it doesn't stimulate the growth of blood vessels. This molecule, again, was really discovered in NIH, and the mechanism of how it worked discovered there by Dr. Burton Zabara's group. And through that, once you know what the molecule is, you can begin to develop drugs or drugs that target the molecule. And the first drugs were called tyrosine kinase inhibitors. And basically, a lot of the signaling in the cell works on putting another chemical or another molecule onto it. And the signaling molecule is phosphates. And so they add on what's called a phosphatase, and it makes the molecule active, so it stimulates growth of the cell in most cases, or growth of blood vessels. The other common abnormalities, The other common abnormalities that occur in cancer cells, once they can stimulate growth, and once they can stimulate the growth of blood vessels, is that they then need to take the brakes off the cell that are put on by the cell saying, I'm sick, I need to not do this. But the way of taking the brakes off is they get rid of molecules that are on the DNA that allow it to express things that normally would be repressed as you get older. So your cancer cells are you, and you start from one cell, and then your cells keep dividing and they become specialized. So they become muscle, they become eyes, they become bowel, and they become kidneys. But they have to migrate around and move throughout the body. And once they become abnormal, then they can revert and they can start expressing the DNA or the genetic material that tells the cell how to behave when it's a developing cell, which allows them to spread and move around. All right? So these are the genes that are being looked at for being targeted in treating kidney cancer. When we talk about cancers and kidney cancer, we talk about stage. And stage is a way to allow all people treating and caring for kidney cancer to understand what they're treating and to divide it up into groups that get different treatment. So staging system that's used is called the TNM staging system. T stands for tumor, N stands for lymph nodes, which are the filters that filter blood that leaks out in between the arteries and the veins, and M stands for metastatic or distant disease. So early kidney cancer would be a stage 1, and T1 is a tumor up to 7 centimeters in maximal diameter, and it's broken down into A and B. So a T1a is one that's less than 4 centimeters in diameter, and it's very small and early in the detection, and it behaves in a way that's not as aggressive as a T2 tumor. A T3a tumor is a tumor that's starting to invade into structures around the kidney. And then T3b tumors are tumors that can actually grow back through the veins and grow all the way back up through the big vein that I was telling you about. What we don't really understand is how renal cell cancers get into lymph nodes. We know it gets into the blood system and can spread around in the veins, but how it gets in the lymph nodes we don't truly understand at this time, and a lot of research is looking into that and what needs to be done with the lymph nodes. I was telling you about the imaging for renal cell cancer. This is how we stage it to know the extent and how much there is. That's staging. This is a CT scan here, and the CT scan basically can make images of you cut either across like you went through a bandsaw or longitudinally through a bandsaw, and we can analyze where these tumors are, what the kidneys look like, and if the tumor is spread around to other areas. In this particular case, it's sort of like the old Sesame Street story. One of these things is not like the other. So this is the liver here. This is air in your colon. This is air surrounding the patient. This is bone at the back here. And when X-rays strike bone, it doesn't go through, so it's white. If it goes through air, it easily gets through and it makes a black spot. So this is the bone. This is the spleen, which is an organ that filters the blood to take out abnormal blood cells. This is the aorta, the big pipe I showed you at the beginning. This is the inferior vena cava that takes blood back. And this is the right kidney, and this is the left kidney. And you can see here this round lesion that's pushing and growing is a tumor involving the left kidney. This can also be imaged on ultrasound that is not as clear to the untrained eye. It looks more like a snowstorm. But again, here's this round image in a kidney with increased blood flow through it. So these tumors are very highly vascularized and can be detected by these imaging modalities, which is the most common way of detecting cancers now. So in the 1970s, when I was a young student, only 10% were detected incidentally. Most people had to present with bizarre symptoms, blood, weight loss, or feeling unwell. Nowadays, most people present with early detection by the radiologist. So we used to know them as the internist tumor many years ago, and nowadays we know them as the radiologist tumor, and they're referred after a radiologist has seen them. So stage migration basically means that rather than being detected when you're either small or large, you're being detected now, in this case in kidney cancer, at a much earlier stage. And you can see for the types of kidney cancer here, the very early stage ones are going up and up, and the more advanced stages are going down, but some of them that are very aggressive are staying the same. Does everybody understand that concept? Prognostic factors. These are things that mean how well your tumor is going to behave, right? So you want to know how aggressive the tumor is going to behave. And HR stands for hazard ratio. So the grade of the tumor, as it gets higher, which means how aggressive it looks, in some cases under the microscope, we use what's called a Fuhrman's grade. The higher it is, the greater the risk that tumor is going to behave badly. So a grade 4 versus a grade 1. So unlike school marks, you don't want the high grade, you want the low grade. Gives a hazard ratio of 5 times higher risk of this behaving badly. If we look at invasion, so the hazard ratio if its tumor starts to show invasion versus no invasion is as high as 5. And then the size of the tumor greater than 9 versus a smaller tumor, the hazard ratio is only 1.2. Other things that influence how well your tumor is going to behave is associated disease with the kidney cancer. This is a table that looks at all the different things that are associated with looking at stage, performance status of the patient. And what I really want to point out is that the size of the tumor really has a low impact on how badly you're going to do. We know that it has an impact if it shows invasion. We know that the bigger the tumor gets, there's a slightly higher risk of it not be performing well, but it's not a huge amount. So if you can save the kidney and not have to get rid of the kidney, the outcomes are pretty close. This is an active slide, so it's supposed to highlight it. Oh, there it goes. So again, the tumor size risk or hazard ratio is only 1.14, and it's only as high as 1.2, as I told you before, and this is from a large study. So history of renal surgery. So I'm a surgeon, and I've come along a lot later than these guys, but the first nephrectomy was performed only in 1869. And we didn't have the luxury of antibiotics at that time, nor an anesthetic. So that would be a big operation. Shortly thereafter, this surgeon here performed the first partial nephrectomy. The introduction of cooling off a kidney to perform surgery was first introduced in the early 60s or late 1950. And I told you before that these tumors the kidney uses a large amount of energy. So if you're to get sick and have low blood pressure or not do well, the kidney is one of the first organs to suffer from that and run into problems where it doesn't function. In 1963, Dr. Robson, a surgeon in Toronto, actually set the standards for how we manage locally advanced kidney tumors. And I told you, back in the 60s, we didn't have imaging, so most of the tumors presented very large, like this big lump here, and required a big cut to take it out. And everything was removed all at once. So in that time, we were seeing tumors late. Nowadays, we're seeing tumors early. This gentleman here, Dr. Andy Novak, who is also a Canadian from Montreal, he moved to the Cleveland Clinic, pioneered a lot of work in nephron-sparing surgery to save as much kidney as possible. He was a transplant surgeon, a vascular surgeon, and believed that you actually needed to save as much kidney as possible. We still didn't know who should be saving a kidney and who should not when he introduced this concept of only cutting out the abnormal part of the kidney and repairing the kidney to save kidney function. This is what it looks like in my operating room. This is a kidney that's been dissected out here. This is the tumor. And once the blood flow has been cut off with this clamp here, the kidney's packed in ice to cool it off, the tumor's cut out, and then the kidney's repaired, just like in the picture of Dr. Novak. Technology that's come along since Dr. Novak and the training of myself has been laparoscopic surgery, where you can actually put cameras and everything inside the belly and inflate it up to try to reduce the complications of open surgery. Dr. Clayman in 1991 performed the first laparoscopic radical nephrectomy, and shortly thereafter the first partial nephrectomy done laparoscopically was performed. Not all kidney tumors, though, are easy to treat laparoscopically. Some are easier, some are located away from where the blood vessels are and the collecting system, so they're further away or they're small, but some are right in the center and are bigger and more complex to deal with, which usually requires open surgery as opposed to laparoscopic surgery. If we look at the group at the Cleveland Clinic, and we look at the outcomes between laparoscopic and open surgery, the open surgery still outperforms laparoscopic partial nephrectomy, but laparoscopic partial nephrectomy is improving with technology and advances to be able to do even the most complex cases. This is a robotic device that's used to assist in doing or laparoscopic partial nephrectomies, and it uses a robot very similar to what you would see in an assembly line in a car plant or a manufacturing plant of other types. And a person sits at the console and controls the arms of this robot to control arms inside the belly so that it can cut out the tumor and then reconstruct the kidney. And basically to do that, they still have to stop the blood flow to the kidney, but it's more difficult to cool the kidney in this situation. Dr. Gill, who also used to work at the Cleveland Clinic but is now at USC, has come up with greater strategies of using laparoscopic or robotic surgery to do partial nephrectomy, even in some of the most complex cases, with what's called zero ischemic time. So in other words, rather than clamping the kidney, they basically dissect down from the hilum, pushing the blood vessels away, and get into the kidney where the tumor is and take it out without having to stop the blood flow, and thus reducing damage to the kidney while it's being operated on. So I told you already about chronic kidney disease that can occur when you lose kidneys. And Dr. Go was the first to point this out in 2004 when he studied over 1 million patients. And what he showed is that as the GFR, the filtration rate, goes down, the risk of developing death goes up. And we know that. We know people that are on dialysis or have renal failure are more likely to run into problems. But the event, even with a slight decrease in kidney function, the cardiovascular events go up, hospitalization also goes up. So the people at Memorial Sloan Kettering began looking at why aren't we getting greater survival rate if we're detecting cancers a lot earlier? And if what we were doing is with the new technologies came in, we were still taking out whole kidneys instead of doing partial nephrectomies. Not everybody had a knowledge translation or uptake of the data to manage kidneys that way. So people were still losing a whole kidney when potentially they could have had just a portion of the kidney removed. And this is the difference in survival, whether you have a partial nephrectomy or a radical nephrectomy. So removing the whole kidney had an adverse effect over a partial nephrectomy stage for stage. We looked at our own data here in Alberta as a population base, and we found the same thing, that if the whole kidney was removed as opposed to a partial nephrectomy, you would have a poor outcome as far as cardiovascular side effects, and it could also potentially limit what treatment you get down the road as far as treatments that Dr. Pasapa is going to talk to you about. We also found that if you have higher comorbidities, your risk factor for death also went up. It was also influenced by the chronic kidney disease. So if we look at what happens for these T1a lesions, and we look at a GFR of greater than 60 preoperatively, if you had a radical nephrectomy, here, the mean change in postoperative GFR was 33 mils per minute versus a partial nephrectomy, which is only 16, or half of what was lost with removing the total kidney. We also looked at this in the lab in experimental models, and I told you as you age, your kidney function is lost, but what happens when you all of a sudden take out a big chunk of kidney and you lose it? Does it accelerate loss of kidney function from hyperfiltration, or does it still stay on the same trajectory? And in experimental models, the more you take away from the kidney, the more it has to work to filter, the more likely it is to run into problems with filtration. So if we look at the risk of death while you're on renal replacement therapy, so if you lose a kidney altogether because you develop cancer in one kidney and you end up on dialysis, the chance of dying on dialysis is about 10 to 15% per year for all comers. So you can see that it's important to have a functioning kidney and to receive other treatments. We also know that as people get older, that these tumors are normally fairly slow growing, and not everybody needs to have the kidney tumor removed. So although you hear the word cancer, doesn't mean that that cancer has to be removed or the whole kidney removed, because you may not see a survival benefit from that. In fact, there may be a negative survival effect as indicated in this paper here. So if we look at the natural history of small renal masses in an elderly population, so somebody that presents with a small lesion that isn't in very good physical shape, how can we manage that? Well, in a lot of cases we recommend just active surveillance, which means keeping an eye on it and seeing how it behaves rather than actually treating it aggressively. And you can see here that only 1% in this population of over, I think it was 286 tumors, actually went on to progress the spread of the cancer. So it's a very low risk. And if we look at the growth rate and monitoring a plot of all the different patients with their tumors, some shrunk in size, some went up in size, but on average, most of these small tumors stayed the same size over a long period of time, again indicating that not everybody needs to be treated. So what are other treatments for small renal masses besides surgery? There's radiofrequency ablation, so you can heat it up with radio waves by putting this needle with these tines in it and heating it. The complication is to surrounding structures. Fortunately, if the tumor is behind, there isn't many surrounding structures, but you can get fistula that form, and you don't know the completion of the treatment with radiofrequency ablation. There's also cryotherapy, where you can, again, put in a needle-like probe and freeze the tumor solid to avoid surgery, so minimally invasive techniques. Again, you don't know your margins, but in this case, there's less potential collateral damage, and is offered for treatment. And it's offered for treatment also when the cancer spreads around in areas that aren't readily accessible to surgery. This is a picture that is a diagram to show what happens if a tumor grows back up in the vein. It can go all the way back to the heart. And again, I told you the only cure for this cancer is to cut it out. All the new drugs and all the things we have don't cure the cancer. And we go to great lengths to cut out the tumor. And in fact, we put people on bypass, where we put the heart on a pump, where we pump the blood for them. We cool them down and then dump all the blood out of the patient. So basically the patient doesn't have a heart that's beating. It's sort of preserved in time, cold. We cut out all the tumor, put everything back together, and then sew people back up. And the survival rate for this is as high as 47% at 5 years. So this is an example. This is a 52-year-old male that presented with hematuria, with an advanced tumor. You can see this is his tumor involving his right kidney. This is a normal left kidney. Here's the pipe taking blood back to the heart, and this is the tumor growing back up. And basically we can take out the whole kidney here, and with the thrombus going back up to the heart, and then put everything back together. And patients do very well, but they may need to see Dr. Basapa down the road for further treatment. This is what it looks like in real time. This is a patient that we operated on. Here's all the heart here with all the pump and tubing coming out to put blood in and out of the heart and to cool everything down. This is the liver that lies over top of the kidney. Here's the inferior vena cava that takes blood back, and here's where the right kidney used to be here. So extensive operations, but people do well. I'm going to quickly jump ahead with these new molecular therapies, or TKIs, that I've told you about. They're the new thing. We don't really know how to totally use them yet. But the controversy comes in surgery as to what should be done if you have a big kidney tumor and you have metastatic disease and you're being offered tyrosine kinase inhibitor therapy, Sutent, mTOR inhibitors, so everolimus, and pazopanib, and some of the other drugs that Dr. Basapa will talk about. These people still benefit, despite these newer drugs, reduction in the mass or tumor. So it's called the cytoreductive nephrectomy. So cytoreductive means that we take out the big kidney mass that's in there, even though you have metastatic disease. You have to have a good performance status to undergo this. So you have to be in pretty good shape and health. And if we remove the kidney, the survival is still better in somebody who's had the kidney removed, even though they have metastatic disease, versus somebody that does not have the kidney removed. So these are people that have to be selected appropriately. And then once you develop metastatic disease and you've been treated with a tyrosine kinase inhibitor or mTOR inhibitors or immunotherapy, then some will respond and they have just residual disease. And Dr. Basapa and I shared a patient recently where we then go back and take out a metastatic deposit that's the only deposit still growing. And people do well with that as also. But there isn't a lot of data around that to support directed therapy, all right? So what I'm presenting to you up front are things where we have data to support the type of treatment you get. And I'm going to close there, and we can all jump in and ask questions. These are my offspring when we're out vacationing, and they like to take a chance. So it's lots of fun. So Dr. Basapa, your turn.